So let's move to the third session. We have a very good session next ahead, that is predictor and management of complications. Before starting the session, I would like to invite our worthy chairperson to come and join the chairperson seats, Professor Brigadier Kaisar Khan, Professor Javed Akbar Syal, Dr. Mohammad Saeed Alam, Dr. Awais Nizami, Dr. Tariq Shafi, Dr. Tahir Almani, Dr. Amir Hussain Bandesha, and Dr. Muhammad Kalimullah. Thank you for joining us. So without any delay, I want to invite our first speaker, Dr. Tariq Abbas. He will going to discuss the access site complication, that is femoral and radial, its diagnosis and treatment. Dr. Tahir Abbas.
Assalamu alaikum. I just want to inform that Dr. Tariq Abbas was late today, so I, Dr. Badar, was going to present this on his behalf. Well, the topic I understand is not, something when people usually come for this sort of conferences and workshops, they expect something new, something advanced. But this is some basic thing, but really important. Important from the point that if we are stuck at this level, at this point, we are not going to do anything. So, access site complications. I always say to my juniors that we do not learn from experience. We learn from reflection of our experience. Experience is we have seen something and we have done something. It may be the way it has to be done, or it could be the way our senior has done it, but it could be not the exact way what scientifically has to be done. So some reflection is really required to sort out our complications. Well, successful vascular access is paramount in the performance of invasive procedures. An uncomplicated hemostasis of access site is key to success of invasive procedures. Whenever we think of any complication of access site complication, whether two major sites are commonly used in 98% of the cases, either it is femoral or it is radial. There are patient factors, there are procedure factors, and there's something associated with the technique, like hypertensive patient with peripheral vascular disease, smoking, obesity, women, age, and anticoagulants. Any procedure requiring introduction of a long sheath, length of cannulation, length of procedure is very important. Use of anticoagulation, and failure to achieve hemostasis post-procedure. Again, there are factors associated with the technique, site of puncture, the arterial site hit by us, up, down, at the level of the target or not. Double puncture, while we can puncture both anterior and posterior wall, and sometimes there are through and through puncture. Whenever we are doing any procedure in the cath lab, believe me, it's not important what happens. It is, but most important is how we react to what has happened. And this is true for complications in the cath lab. Just to start with the femoral artery access, just a brief idea. I mean, you all are very well aware that site of the puncture of femoral artery is basically in front of the femoral head of femur, where it is just before the bifurcation of common femoral artery. And there are two views, a diagrammatic view and an angiographic view. The complications which can occur with the femoral puncture, like groin hematoma, pseudoaneurysm, AV fistula, retroperitoneal bleed, acute limb ischemia, dissection, neural injury, infection, or sheath or catheter clot. These are the number of the complications which can happen with the femoral puncture. But the most important thing, mostly the most important complication is someone saying that the patient has got hypotension, sweating, pain in groin or low abdomen, and tenderness on the groin. Two options: hematoma at the site of the puncture or retroperitoneal bleed. If there is a hematoma, we can mark the area of swelling resuscitation with IV fluids or blood if required, pressure dressing, ultrasound to see the size of bleed, to size of collection and arterial site puncture, and then observation. 99% of the cases, if it's not a very large hematoma, with observations, with resuscitations, it will resolve after 24 to 48 hours. But what is this then? Most of us has seen in our cath labs, maybe once or twice, a bleed from the artery and an indentation of bladder. This is something alarming. This is now retroperitoneal hematoma. Although incidence is very low, almost less than 3% nowadays. Associated with high puncture, use of medications, posterior wall pain, rupture, puncture, or associated most common symptom is flank or back pain. Hypotension mimicking vasovagal because it's usually associated with bradycardia. How to diagnose? CT image of the pelvis is of choice. We can do iliofemoral angiogram, can identify the site of perforation from the contralateral sides to see. Again, initial treatment is fluid resuscitation with crystalloids and blood transfusion, may be treated with contralateral access with balloon tamponade or use of covered stent if we can identify the site of perforation. Rarely we have to go for emergent surgery. Again, this is the duplex scan of femoral artery. We can see, what's going on here. There is some bleed and some neck of the bleed, and then there is a collection. This is pseudoaneurysm. It is the communication between artery and overlying hematoma. Blood flows intermittently during systole and diastole into the hematoma, normally associated with low femoral puncture. Puncture of superficial femoral artery could be due to large sheath size. And again, in Pakistan, we are not usually using angioseal or exoseal or perclose. Normally, we are here in Pakistan, in most of the sectors, especially in government sectors, manual compression is given. And ineffective manual compression can result in this. Anticoagulant use or antifibrinolytic therapy. Now, mostly it is pulsatile with a buoy on it. Normally, duplex ultrasound will usually diagnose this. At times, CT or angiography can be required. Again, the treatment is ultrasound-guided compression. What we do, we identify through the ultrasound the neck. If it's not a big neck, it's not more than 3 centimeters, some say less than 2 to 3, then we can compress it with ultrasound probe. Very rarely, surgical repair is required. Again, there is a complication like AV fistula. It's a communication between femoral artery and femoral vein, mostly associated again with low puncture because profunda femoris vein lies very close to superficial femoral artery. Multiple punctures, through and through punctures, and overlying of the vein. It is associated with abnormal sensation of groin, in the groin, a vibration because of the flow of the blood. After some time, can result in fatigue due to shunting, varicose veins, and low extremities edema. Can patient present with the Steele syndrome with intermittent claudication of distal limb ischemia? Duplex ultrasound is the test of choice. Small fistula usually closes by itself, spontaneous thrombosis occurs. In this also, like in pseudoaneurysm, ultrasound-guided compression is useful and it can help out. Very rarely surgical ligation or endovascular repair using a covered stent or coil embolization is required. I hope you can appreciate what is this then. Mostly, at times, fellows come up with this, that now the wire or sheath is not going up, the catheter is not going up, and this is the picture. Dissection. It is retrograde, usually. Needle or guide wire entering the dissection plane through the intima. Sheath is up against the wall of femoral artery, discovered on femoral angiogram and usually asymptomatic, since it is antegrade. The beauty is, it's the blessing, it's antegrade, so it's usually asymptomatic. rarely results in complete occlusion of femoral artery when there is overlying thrombus formation or with continuous injection in the dissection plane of the dye, it can result in the occlusion. Pain in the leg and signs of arterial insufficiency. Treatment is we withdraw the sheath, contralateral access with attempted percutaneous or surgical approaches in case where it is symptomatic and where it is causing severe pain or signs of ischemia. What is this? Patient had an angiogram like 8-9 hours back, pain in the same leg, and on the first view you say, oh, this is acute limb ischemia. Thrombus at the site, most likely, most of the time is due to femoral artery dissection. Well, embolization of foot plate of angioseal. Now, the angioseal devices which we are using, they can also they can embolize at some time when they are not properly. We have to pull them. When they are not properly pulled, they can embolize. Suturing of the circumflex of the artery with per-close device, like in the procedures using large devices like TAVI or mitral valve clipping. Mostly in TAVI, we use this per-close device. Then the suturing can occur through and through the artery. Risk factor is small caliber artery, especially in women and those with peripheral arterial disease and diabetics. Large sizes sheath, long catheters, long dwell time. Superficial femoral or profunda cannulation because it is small and catheter vessel mismatch is there then. I think it's not uncommon to say that 5 Ps of ischemia are there. Now the treatment is prompt contralateral access. If there is threatening limb ischemia, the best is to contralateral access and angiography and thrombectomy and stenting. Intra-arterial fibrinolytic or surgery at times can be used. I know it's really, maybe it's so boring, because it's, it's below your level. So we should not be so serious. Now coming to the radial artery. 4 variations. Most common A, could be B, high bifurcation of brachial artery. Rarely it's C with the loop, and very tortuous. Very, we can get spasmodic is D. Normally, its radial arteries access 1 to 2 centimeter proximal to the wrist. True cell danger technique is very good, very helpful. Radial artery access, with ROST study, there is benefits of a lot of data is coming out. Then we should do this radial artery puncture through ultrasound guidance. The success rate is very high, and later on the complications, especially in longer procedure in acute settings like ST elevation MI, are rare. Again, complications are like radial artery spasm, hematoma, compartment syndrome, infection, abscess, pseudoaneurysm, hand ischemia, artery avulsion, and radial artery occlusion. What happens here now? What was B and what happened to A? Throughout the diameter, throughout the caliber of the vessel is reduced. Most common cause of procedure failure is the radial artery spasm. Incidence decreases with experience. Radial artery spasm refers to friction between the artery and the wires or guide catheters accompanied by subjective feeling of pain. Pain from RAS increases vasomotor tone, resulting in further spasm. Now, younger age, female gender, diabetes, small wrist circumference, lower body weight, multiple attempts, and sheath characteristics are basically the predictors of spasm. How to prevent this? Intra-arterial administration of antispasmodic medications. Everyone is aware of the cocktail we are being used. Calcium channel blocker, a nitrate, including the heparin as well. Hydrophilic coated sheets, now they are coming in, they are good. And long sheets. The shorter the sheets, now again, there is a lot of data, some favoring that the shorter the sheath, the lesser the spasm. Again, there is other group favoring the longer the sheath, the lesser the spasm. Rathore found no reduction in spasm in long versus short sheaths. However, there was high rate of radial artery occlusion at 4 to 6 months follow-up visits with the use of longer sheaths. When clinical spasm does occur, it can be treated with repeated dose of IA intra-arterial vasodilators, local anesthesia, analgesia, and sedation. In extreme cases, an axillary nerve block, sedation, and general anesthesia can be used. Radial artery occlusion, to prevent this, we use Allen's test or Babu's test. Everybody's know that, to see the saturations and the blushing of the hand after occlusion. The radial artery predictors of low body weight, advanced age, female gender, degree of systemic anticoagulation, hemostasis process, again low radial artery diameter. Management is use of either, we use this, we use heparin in every procedure of transradial access. And last, hematoma, easy hematoma classification. It's used to classify and to treat the hematoma that rarely occurs after the radial approach. Thank you very much.
Thank you very much. Although the access side is very huge topic, it's difficult to cover in 10 minutes. But I request to the upcoming those who are coming, it's better to finish your presentation in 10 minutes, so we can go forward to discuss in our question and answer session. I would like to invite our second speaker, Dr. Mahmood Hassan. He is about to discuss the aberrant vessel closure, spasm dissection, no reflow, and distal embolization. Thank you.